Now, at lunch we had that report, Counting the Cost, that was launched officially on the social and economic return on investment in terms of cancer therapies, particularly focused on people with young children, but we can extrapolate a bit beyond that, and I'll just remind you that it talked about investment that improves the survival of non-curative cancer beyond 5 years. At every $1 invested returned $3.06 in social value, which is a powerful reminder, again, of what we're talking about. But I'm going to read a quote from that to sort of start off, because I think it sets the tone of what we're talking about today. When the Pharmaceutical Benefits Advisory Committee determines a drug to not be cost effective for a particular type of cancer, people die and families are torn apart unless they can raise the many thousands of dollars required to self-fund their treatment each month. And we've heard examples of that, including most recently from Angus. Yet in many cases, the impact of those treatments on their lives and the benefits for their families are considerable and long-lasting, particularly for children. In other words, not improving the quality of life and prolonging the survival of people diagnosed with cancer costs more than the financial investment in the treatment intervention. Whether we recognise that and how we assess the cost effectiveness of that treatment in the future through our health technology assessment processes speaks volumes about the value we place on a person's life and the impact of spending more time with their families. I want to sort of go back to first principles, I guess, and maybe ask a sort of a very basic question to start with. We'll see who'd like to answer it. But we'd love to fund everything. Is it realistic? Can anyone tell me? Is it realistic to think that we can fund and subsidise all cancer treatments for all patients? Because really, that's the most horrible of the horrible questions underpinning the whole system. I don't know, Michael, do you want to start with?
Sure. So sadly, I think the answer is no. Or at least you can't just unambiguously say, yeah, you know, it's just as simple as that. Let's just fund everything. So I know you had the PBAC session earlier, but to me, the challenge is thinking hard about what the differences might be between the sorts of listing deliberations you have around, I'll call it a kind of run-of-the-mill drug on the PPS, where you're thinking about quality-adjusted life years, it's a statin, it's a this, that or the other, versus the drugs where the stakes might just be a lot higher, right? So it's lives and there's something a bit more fundamental about it. And you know, at various times the PBS has had that attempt to try and parcel off, you know, do we need a special set of considerations to apply to life-saving, high-cost life-saving drugs, or you know, drugs that will inevitably only be focused on a small part of the population, and allow for the fact that there has to be a bit of flexibility and maybe some different considerations that apply in those instances, but still trying to put a framework around it. So I think, yeah, the mistake would be to be totally one size fits all, the total kind of economic rationalist, no, it doesn't add up. You do need to think differently about some drugs and some circumstances than others. You do need a bit of flexibility, but there will be, at the end of the day, there'll be some framework you have to put around it. There will be some choices and some of them won't be easy. And, you know, it will mean that you're approving some things that have a higher cost than a lot of run-of-the-mill drugs, but yeah, can you fund absolutely everything? Well, sadly, probably not. There will be things where a line will have to be drawn, I suspect.
And I think the challenge is that, and it's interesting for breast cancer to be on a panel for rare cancers.
Yeah.
And I've heard often today, and I think we hear it through the whole industry of, you know, the large tumour groups, of which I'm well aware that I'm representing that group. But the more and more we understand about cancer, the more rare cancers evolve. And so some of the big tumour groups are now dealing, you know, our people living with metastatic disease are clearly more relatable to rare cancers than they are to the early breast cancer setting. So the more research we know about specific tumour types, the more rare and rare it's going to become. So the system is going to become more and more difficult to get up in the current way we evaluate all drugs. So absolutely everyone is going to be in the same situation, no matter what kind of disease you get, the more we know about that.
Yes, so the more sophisticated our tools become for drilling down into different kinds of cancers, the more each one will become very specialised, and we will stop talking about cancers as being lung cancer, breast cancer, one big generic group, that there will be smaller groups, and that the challenge, I guess, in volumetric assessment comes in there. Peter, you're also, at the coalface of dealing with people facing this problem. Where, if I say to you, where do we draw the line? How do we draw the line? What do you say?
I think we need to change how we assess. So I think the assessment process needs to incorporate the types of values and the types of costings that we've included in the report that we've released today. And I agree with both Kirsten and Michael, which is there are going to be some cancers which they are rarer, and that is true for adolescents and young adults who their cancers. It's true for probably many of the people in this room. The cost equation is always going to be stacked against them. So we heard Sarah just describe in such a compelling way her many years of lived life, but out of her pocket, and she's going, but it's not fair, it's not right, and she's absolutely right, because the person in the house next to her might have had a cancer that's in one of the larger groups and had access to many pharmaceutical options to treat that cancer. She's got a very rare cancer, and it came out of her pocket. So we need to set it up so that somehow that can be addressed, because she is living a very full life. She is an absolutely wonderful contributor to the community. Same for Joey. Palliative in 2015, 7 years though of providing incredible value to this community. And so yes, we can't blanket say, well, any drug that comes across the counter, we will say it's suitable for all cancers, we don't care, and anyone can use it. You still need good clinical judgment on that, and you still need to think about it carefully. But we understand the genetics of cancer more, so we can start to then think about how we approve cancer pharmaceuticals on that basis. In the past, we're going, okay, this is just approved for bowel cancer, as opposed to, it was great to hear Andrew talking today about, we're now looking at PD-1 inhibitors and how we provide access through the PBS for them.
And I think another thing that Andrew from the PBAC brought up was this issue of inflexibility in the system. Zoe, earlier Andrew spoke about it, as I understood it, some of the difficulties in the system being set up to be based on the nature of a submission from a pharmaceutical company, and that for reasons of practicality from the company's point of view, in terms of getting something approved, they might put in a submission, as I understand it, with a sort of narrow application to one kind of cancer, when it might actually be applicable to other kinds of cancer in those smaller groups, like the groups that you were just talking about, Kirsten, but it's not approved for that. What do you think about how the system is set up? Do you think it could benefit from something inbuilt? And he's making the point quite fairly. He's making the point that they're at the end of the line in terms of the assessment, that there's governments making law and other stages in the process. But can we adjust the system to build in more flexibility so that we don't have to depend on clinical trials of very, very small groups that are really never going to occur, and you'll end up with a drug that could be applicable to another group only funded for this group?
I think there's a huge opportunity to think about how we can do the system differently, and I know that a lot of industry is really interested in how we think about risk sharing in some of those spaces, financially speaking, so that we can really focus on an outcome base and recognise how we can build that into some of the assessment processes. I mean, I think I made the point, but it's an observation I had an opportunity to make in a pretty high-level forum about value-based healthcare, and we had industry and we had government and we had not-for-profit and we had consumers around the table. And it was really clear that whilst individuals trusted each other in the conversation because they knew each other, the system was designed so that they couldn't trust each other. And I think part of what you're talking to is inherent in that we actually really need to think about how do we align the stakeholders' incentives about the outcome that matters to the patient.
Yeah, and I think yesterday we met around the Australian Cancer Plan, and there was some discussion in the chat that actually PBAC are doing some great things about trying to involve consumer groups earlier in their decision making, and I think we want to encourage that. But it is actually about those meetings before the submissions come up, and it's, it is getting in what matters to patients before the submissions are being put together so that we can have a united front but keep that independencies that are important in the system. But I just wonder, because speed is a real issue right now and is possibly one we can deal with.
At which point in the process, or all
The whole way through. So very quick snapshot. So we have a zoledronic acid. We know it can reduce the risk of recurrence of breast cancer. So you would think pretty important investment to make. Not enough trials around. No pharmaceutical company are going to benefit financially from it. And the perversity of the system is that unless there's commercial interest for everyone, why would they put it up? We've ended up finding someone to do it. And then TGA turn around and say, well, it's going to take 222 days for us to review a drug that has been working for like decades. Yet we have to now wait another 200 days to review it. It's a ridiculous system. So I think speed is really important, and that to get speed, we're all going to need to invest in that. To get a managed access program, we've all got to be prepared to put some skin in the game to say if it's not working, then we've all got to play the part of pulling it out of the system. It's challenging, but I think it's one that we need to think about. If speed is getting drugs to patients is really important, then we need to rethink the way we're currently working the system while we look for a better way longer term.
Were you going to say something, Peter?
Yeah, so I was thinking about when, was it Rick Padsua, who heads up the oncological arm of the Food and Drug Administration, came out to Australia, and it was pre-COVID possibly, I can't remember, I'm losing track, but he was talking about his driver is how quickly he can get drugs out to patients. So that's the thing he is most focused on, is trying to get new drugs out to cancer patients that may have a positive impact and collect further data as they are taking the drugs and using them. I think he's got a team of 100 oncologists sitting behind him to assist with the assessment process. So that then means the speed with which those new pharmaceuticals are assessed and taken through to the point where they can be released to patients is much shorter. And so they're doing that very quickly. They're also trying to assist other countries by involving Australia and New Zealand, and there was another country they mentioned in their discussions, and I think they meet monthly to try and update our countries on their assessments and their progress and their findings. So it does also beg the question of why does every country have to assess it completely separately for themselves? And, you know, maybe the FDA's 100 oncologists might have a better crack at it than our 2.5 people sitting in Canberra.
Zoe, and then I was going to ask Michael, do we need to shop around internationally then? Do we need to get our heads together? Can I just ask you that first? Yeah. Well, is there a solution to that?
So I'm no expert, but it does seem that and this is replete across a range of regulatory areas.
Right.
Where, you know, what is, I mean, just to tell a little parable, right?
Please.
The last couple of years, the various state treasurers got together and at long last sort of cracked the question of automatic mutual recognition of a whole range of occupational licences, right? So if you're licensed as a plumber in South Australia, why can't you practice in Victoria? Just sort of as of right, whatever. As a principle, it's a really good one because what it really goes to is trust. If I say that South Australia's got a robust system to, accredit a plumber, I'm not going to kind of kid myself that I'm so much better as a Victorian or something, then why not? And I think, you will have some instances where you can make a case that there's a population difference, I guess, around, an Indigenous population in a particular country, or that there will be some genetic issues or whatever. But for the most part, why we can't have greater trust and recognition of robust overseas standard setting, I think it's quite a big agenda, to be honest, across a whole range of regulatory issues, and drugs are one that come up a lot.
Thanks. Zoe, you were going to say something?
I think there's a real opportunity to learn from COVID in this space, because we saw very rapid adoption of technology that was taking, well,
We all got on with it. Amazing.
We all got on with it. Telehealth, who would have thought it was that easy as just turning it on? But we also saw the same...
I know people who still don't love it, can I say?
Yes, they don't love hospitals either.
No.
But, you know, I think that how do we actually learn from that speed to market of the vaccine development to, you know, to getting it into people's arms, and same with the antivirals. There's the real opportunities for us to capitalise on what we saw happen, because the level of risk was so high to our community that drove it. But I think it's really important for us to learn those lessons and take them forward.
But it requires greater transparency, and everyone has to commit to having skin in the game. And I think that's where that trust element that Zoe spoke about. We've got work to do around trust and the way the system can actually work, and that means having conversations earlier, not at the end, which is what's actually happening right now.
Yeah, it does strike me there's a little bit of the old ambulance at the bottom of the cliff idea about this. So let's talk about transparency. Why is the system not transparent, and at what points of the system do we need to make changes to improve that? And any of you?
Well, I'll just make a note, and then I might throw it to Zoe. But I love that we're measuring outcomes. I don't actually think we measure outcomes in cancer care right now. We measure activity, but there's pockets of activities, you know, measurements of outcomes, but there's not a consistent approach to measuring out. I mean, we don't even know how many people are living in this country with metastatic disease. Like that, how do we measure outcomes when we don't know the base number? That's
a data collection problem, is it not?
Yeah, but that's about that transparent. There's so many elements of transparency that play into that. And as Michael said, that interconnectivity with the whole system that's so disparate, the states, federally, and then international layer.
And again, we don't incentivise the collection or understanding of outcomes either. You know, we punish hospitals for having hospital-acquired complications. We don't say, hang on a second, we actually probably need to invest more in that hospital if it's struggling. So we actually inadvertently, you know, set up kind of gaming of the system so that people feel not safe to say, actually, we're not getting great outcomes, how do we improve? How do we move more to a carrot than a stick approach as a system, I think would really assist with some of the transparency in those elements.
Doesn't this come back in the end to the fact that that trying to define value is very subjective, trying to define cost effectiveness is very subjective, because by what measure? And maybe the lack of transparency is because it's easier to make some of the hard grey area decisions away from the public eye. I was thinking about what Anne said earlier, I think, about having a patient committee make these decisions. And now if I was on the patient committee, I'd be funding the neuroendocrine cancer advocacy, of course. But, you know, there'll be other people who have different priorities. Is there a non-subjective way to balance up these wicked issues? How do we do that in a system? Can we do it better than we are doing it? And how do we do it, aside from the transparency issue, but in that definitional question of value and cost effectiveness? Because we seem to not, I think the arguments today have been that we're not prioritising the wrong thing, or we're defining value in a very monetary sense and not a broader sense. So in real terms, how can we make that change? Yes, this is the problem. Right? Or maybe it's just my inarticulate question.
No, well, I think Andrew was saying, you know, that work needs to be done on the framework, and work needs to be done on the legislation that governs him. As he very clearly describes, he is implementing a system that is handed to him. So when it comes to PBAC's role, the structure, the framework is handed to him. There is a little flexibility in there, but it's quite set, and it was set quite a long time ago, even though they've tinkered with it a bit. It's now taking that system and re-looking at that system of assigning value or allocating value on what you value in that process. And I think we saw really clearly, and the report argues really clearly, I think that when a person in a family gets cancer, the whole family is impacted, and that then has impacts on the system, whether it's health system, their participation in employment, or their participation in education. So we need to take that framework and revisit that, and I hope that that's what the Health Technology Assessment Review process will do. And as part of that, build into it, as Kirsten is talking about, earlier opportunities for patient input. And yes, you know, everyone's going to have a perspective, but I can't remember who it was, they said that already values are driving, people's values are driving the system already. So it's really just reassessing what values are being held up higher than others in that process.
Yeah.
I mean, one of the inherent assumptions in your question is that subjectivity is a bad thing. And I think, in fact, if we think about some of the principles I was talking about that's evolving in value-based healthcare, it's actually about understanding outcomes for each actor in the sector, including consumers, including their families, including doctors, including the broader health practitioners and the system as well, because that's actually how we start to align the incentives, when we understand the outcomes that matter to each player in the sector.
Yeah, can you talk a bit more about those conflicting incentives you mentioned and how the incentives are doing the wrong thing?
Yeah, absolutely. I mean, I think one of the ones that comes to my mind, which is obviously, relatively public challenge, is around device companies and insurers. Now, device companies, obviously, they're a profit organisation, and so they charge for their device. The insurer doesn't want to pay that much. So you've absolutely got a challenge in terms of their incentives of these two organisations with a patient in the middle. And I think it's about, if you can actually say it's the patient outcome that everybody needs to focus on, or the patient journey. And that, obviously at a system level, that can't be an individual, but it has to be informed by individuals' outcomes that matter. That actually then starts to align the incentives, if that's what the agreed driver is, or the agreed outcome that we want.
Michael, you've worked in a lot of agencies that are very numerically focused, can I say? Would you say there is an acceptance in different levels of government, acknowledging that Zoe also works within government, but would you say there's an acceptance of a need to try and encompass these more nebulous ideas about value and to shift the system? And if there is, why haven't we moved? What is it just too hard, or what is it?
So I think there is. I think there's a strong understanding of, for example, the need to shift to a more, Zoe's point, a more value-based healthcare system. And to be frank, it's partly because I think policymakers can see that there is maybe not a fiscal dividend, but there's just a much better set of outcomes that you can get for the dollar spent. So I think when you point out where the incentives just misalign, like activity, it's just activity, right? The 30-minute consult in the GP world, right? That may or may not be the most efficient thing. Treating people in public hospitals is probably not the most efficient way of dealing with a whole range of things. I think that does appeal to policymakers. The thing that, and it goes a little bit to the point I was trying to make earlier about mental health, when you're trying to have a go at estimating the cost, estimating the value of different interventions, I'll say this in defence of people who work in the Department of Finance, right? They see a lot of this stuff, in fairness. They see a lot of quite self-interested sectors coming to them saying, oh, we've got a study by esteemed, consultants showing that there's just huge value in funding us or
So they're
whatever.
trying not to be captured by any one group.
Correct. And I think one of the things, the point I was making earlier about the mental health thing is, okay, do the analysis. Don't take it too literally, but do try and look at some of the underpinnings about what is the point we're trying to make about mental health. Part of the point we're trying to make about mental health, unlike most other chronic diseases, it's hitting people at a relatively young age. That's why you can kind of see that there would logically be a much greater cost over the lifetime than there is for a range of other chronic diseases. I think the point you're making, Peter, is an excellent one about, is cancer different in this sense that there may be a whole range of other pharmaceutical interventions that just don't have quite that dimension around this impact across as I think the document sort of says, it can sort of tear the family apart, right? Well, that's that point about being able to distinguish, the point about saying, that we're getting at numbers here that are telling an underlying truth. I think that's almost what you need. But it is hard. I kind of understand the scepticism that you can get in the PBACs of this world, the departments of finance, etc. Zoe mentioned the challenges of getting Victorian Treasury on board.
When you run a transformation, which is what we're trying to do, you can't do it in small steps. So we kind of need the big picture to be clear about what it is we're trying to do. And then it is going to be a change management program. And that, I don't think we've got the clear end picture in mind of how everything intersects.
So we need to set set the destination.
Yeah,
be
and
clear
work
about it.
backwards, because otherwise we're just trying to chip around at the edges, rather than if transformation's what we want in this area. Like anyone doing a digital transformation knows you need the vision, and then you work back, and sometimes you're going to stand something up and close something down, or other times you're going to move slowly towards it. And I feel like we don't have that clear end in mind to then work back from.
Right.
The real vision.
Thanks. Zoe?
I mean, I kind of came across the principles of value-based healthcare when I was still a clinician, active clinically, and they made a lot of sense to me. What really surprised me was my biggest champions in the private sector were the CFOs and the actuaries, because they deeply understand from a risk perspective and from a modelling perspective, if we can get the best health outcome the first time round, we are going to save money. And so I think that's the point of the model and the framework and the transformation that you speak of, is it's not an either or. It's actually, how do we do this together effectively to meet both those needs?
A bit like insurance companies being at the forefront ahead of governments on working out that climate change is something that needed to be addressed. Anyway, I'll make that as a comment. We're out of time, but I was going to put all of you on the spot, but I think, Peter, I'll just put you on the spot at the end here, if you don't mind. If I gave you a blank piece of paper and said, we're going to redesign the health system to better suit the patients, the people you deal with, what would you put at the top there? What would you say to do first?
You really don't want to have the situation we have now, where you have people so heavily out of pocket to survive when other people right next to them being treated for cancer, but it might be a cancer for which there is a PBS-assisted pharmaceutical, would be treated and have no cost. So fundamentally, I think there are those disparities that we have to really look to find creative ways to address. Will it all be through the PBS? I don't know that answer. I think because we are dealing with some rare cancers, and so maybe the model that we're using, and I think Michael was alluding to it too, that we're using for the PBS works well when we've got larger cancer types, and so then you get that volume, and so you get the sort of cost-benefit analysis working. But we are always going to have smaller cancers that need to be addressed, and so at the moment they're being left out of it. We have to fix that. We really do.
So maybe some kind of parallel funding mechanism that works in conjunction with the PBS to deal with special...
Potentially,
in a more structured way than we have now. Yeah. Right. Well, there's something to think about. That's all we have time for with the discussion, but can you thank our panel, please? Thank you very much. Thank you. You're free to go.